We have, for example, a patient with a specific type of tumor called hypothalamic hamartoma. Those are small tumors that are deep located in the brain. So the open procedure by itself to get into the tumor has some morbidity just because it's a difficult area. However, with the laser, you can pretty much plan your trajectory, insert a little tiny probe into the area and destroy the tumor with a small volume and having the patient being discharged the next morning with minimal complications. We had specifically one boy who had a completely normal MRI. And we're talking about the 3 steps to localize an area in the brain. And definitely when we see a lesion on the MRI, everything becomes much more straightforward. The problem is when we don't have a lesion on the MRI. We have the suspicions of seizures. We have kind of the location from where the seizures are coming from. But the MRI, it's normal. And it's funny to say because when you have a normal MRI, if I tell you you have a normal MRI, those are good news in general, but not for epilepsy. When you have a normal MRI, that means that we will have problems in localizing the seizures because the MRI it's completely normal and I cannot pinpoint, oh, this is the area that we need to destroy. For those patients, there is an additional layer of localization, which is what we call invasive monitoring. So we need to put electrodes in the brain to try to find out exactly what part of the brain is responsible for the seizures. And for this little boy, we found an area in the brain. We implant this patient with SEG electrodes, which is another minimally invasive approach where we put little tiny probes inside the brain. And we localize a little tiny area in a completely normal MRI. So we went there and we follow the electrode that was recording the seizures with the probe. And we perform a little tiny lesion. We're talking about less than 0.5 centimeters. This patient that was having 100 seizures per day completely became seizure-free, and we have now an outcome of approximately 6 months. The combination of a non-invasive method of localization like the SEG with a non-invasive method of treatment with laser was fantastic for this patient. He was out of the hospital in less than 24 hours with 1 single stitch and completely seizure-free, a disease that was causing him so many quality of life changes and so many issues for so many years. Without the localization, without the minimal invasive approaches for localization and for treatment, this patient will likely be admitted to the hospital for maybe 10 to 15 days, would have required a very large incision, a very large resection of the brain tissue. We're talking about probably 30% of his left hemisphere in the frontal lobe, just because we don't have the specificity or the assurance that the seizures are coming from exactly from that point. And in addition, he would stay in the ICU, blood transfusion, and possible complications. I think laser, SEG, those minimally invasive procedures, they are still concentrated in large centers, in larger epilepsy centers. However, the future will bring this technology to multiple areas, like happens with epilepsy surgery. In the beginning, epilepsy surgery was done in very, very specifically hospitals with a lot of resources, and over time, again, with the better selection criteria, with better techniques, this can be done in many, many other centers. So time will bring more diversification in the areas where we can treat those patients. Those patients are difficult to localize. Many of those patients, they come from other hospitals. Many of those patients, they are considered to have generalized epilepsy because they cannot localize the seizures. So if you have especially patients with a non-lesional MRI, with a normal MRI, if they cannot localize, they cannot just treat because they don't know what to treat. So those are the patients that will come here to the Cleveland Clinic.